Direct from Rio de Janeiro, live Brascrs. I'm introducing here Dr. Thomas Kohnen from ESCRS, the European Society of Cataract Refractive Surgery, and Alejandro Navas from Mexico, from the Society, from the Córnea and Refractive Society of Mexico. So, first of all, I will try Thomas. Can you thank you for coming from Rio de Janeiro, from far, from Germany. I would like to ask you about the innovations you presented here in our meeting.
Well, let me start with this. I'm still flashed. I'm still flashed. I'm here for 48 hours. I gave 6 presentations, at least if I have counted them correctly, but I think it's true. And I saw also Cristo and the Sugar Loaf due to nice hospitality here in Brascrs. Thank you very much for this. Well, in terms of intraocular lens, technology, I think a lot has been changed over the last 10 years. We're working more and more in the PC range, so with other words, presbyopia correcting intraocular lenses, because there's a huge demand worldwide. We have almost like 2 billion people who are presbyopic, and they want to have a solution. They don't want just to have normal cataract surgery. They want to see virtually, without glasses. And now we have a lot of opportunities like monovision, monofocal plus, EDOF lenses and multifocal lenses. And the trick here is really to choose the right thing for the right patient. And that requires a lot of experience, but also research.
So you recently presented here the rate of femtosecond laser with different IOLs. I see that Panoptix and trifocal has more femtosecond rates than the monofocals. Can you explain that?
Well, I because we do very precise surgery, we like to, with a femtosecond laser, we have a defined opening of the capsulotomy. So we call it femtosecond laser capsulotomy. It covers the optic. I think it's very important you have it, on a very consistent, reproducible way. And the reason is you don't want any dislocation in these lenses. These are higher optic lenses, and as long as they stay in the center, they have good outcome. If you have decentered lenses, which can easily occur if you have a decentered capsulotomy, the lens is tilted or decentered to the side. So that's the reason why I use femto. I also use femto because I have, less energy in the eye. And the third thing is usually the femto systems are now digitalized. So with other words, I have directly my, marking system in there, which shows me the axis and toric lenses. As I presented here, I have now almost like 70% of my lenses, PC lenses, presbyopia correcting IOLs, are toric lens because we correct up to half a diopter. We want to have the patient half a diopter, less than half a diopter after surgery, and that requires very often toric lenses.
Oh, perfect. So let's jump here for Alejandro. Alejandro, can you talk about the innovation you presented here?
Sure. First of all, thank you, Takashi. That's a fantastic, outstanding meeting. Congratulations. There were several sessions in Córnea. I think one of the most important was ocular surface with all these keratoprosthesis cases and this simple limbal epithelial transplantation. This is gaining territory all around the world. These complex cases that could benefit where limbal stem cell deficiency in cases with just one eye. I mean, not bilateral, only unilateral. They could benefit with these novel techniques that are spreading all around the world.
Oh, excellent. And do you see any difference from the Mexican eyes, from Brazilian eyes, as a perspective of the research?
There are some important things with these techniques, like the cryopreserved amniotic membrane. Maybe these tissues need to follow up and see the difference ratios, but I think not big difference in the technique and the capacity of these cells to repopulate the damaged tissue, the ocular surface.
Oh, no, excellent. Well, I would like to ask Professor Kohnen about the the classification of the IOLs. I saw the presentation was Can you explain us the
Yeah, the background behind it. We are actually virtually today, we submit that article to JCRS. We worked with a team called, you know, the classification IOL group. Joaquim Fernandez from Spain was, you know, it's a leading author, but we have a lot of team like the president of ESCRS currently, the secretary, the Trey Booker, Dick, myself, Oliver Findel, Rudy Knights is involved. So a good team which has looked at classification. Now, what we figured out is, I would like to try to summarize it in 3 sentences. When you have any premium IOL, presbyopia correcting IOLs, and premium IOLs, which also includes toricity, then you have to ask yourself, number one, what is the optical principle? And, you know, the lenses are defined by this. This is very often done also by companies, but we have independent, you know, evaluation forms to follow. So you have the optical principle. Then you have clearly outcomes, which is published. We have published several articles on this. Many have published several articles. Sometimes a little bit difficult to, you know, compare, because if you don't have 100% the same methods, that's one thing. What makes study comparison sometimes a little bit more difficult. Although we have worked on, let's say, guidelines how to report on IOL-based refractive surgery. It's published in JCRS, also with this group. And now comes it to the last point, and that is the patient-reported outcomes. So what does a patient really says afterwards? There is still a need for more research in this area, and our editorial and our classification system covers all this. Also the new ANSI criteria or the ISO criteria. You have criteria here in South America, which I have learned, and this all comes to, you know, a classification system which is more advanced than we have seen so far. So you will read it soon in the journal. I hope we get it published by the end of this year. And we already talked here, I think for the first time, worldwide, you know, at the Brascrs meeting.
Oh, excellent. See, that's very good for Brascrs. Alejandro, can you talk about some latest scientific publication, something you would like to share with us?
Yeah, sure. We also, well, changing the subject to keratoconus, we also got a very good session of these all combined procedures, and we published in JCRS a few years ago. Not just for not for advanced keratoconus, but for very suspect cases with mild refractions and good thickness. You can combine small incision lenticle extractions when in the pocket. You inject riboflavin and obtain this cross-linking into the stroma. I know it's a debatable and controversial topic, but well-selected cases may have this kind of combined procedures. I mean,
It's very important because we see an increase in keratoconus worldwide, and so it's important that we do more and more research in this area to help these patients.
Yeah, you know, I agree. Well, I would like to open here a last message for Brascrs for next year, please.
You should come. They treat you very well. There is a nice country. People are amazing. Food, it's unbelievable. Then you need to come next year to be here, Brazil.
Well, I would say it's not my natural meeting to come to, because from Europe always to come to Brazil, but I have been invited twice, and you know, possibly I come next year. I fall in love with this country, and it's very nice. It's a very great congress. I really appreciate the invitation, and it was fantastic. So Sao Paulo next year.
Yeah, São Paulo next year.
Yeah, sure.
Oh, see you São Paulo next year.
2025.
São Paulo 2025. Thank you very much.